Okay, why don't we get started? Again, my name is Eric Templis. I'm the Assistant Director at the Tommy G. Thompson Center on Public Leadership at UW-Madison. And I'm pleased to welcome you here today for the webinar called The Opportunities and Challenges of COVID-19 Tracking Apps as Pandemic Control Mechanisms. As you know, one of the big topics these days, back when we planned this, the tracking apps were a big topic, which we'll talk about today, but we may also hear from people about the issue of vaccine passports and the increased attention that they're getting. Now, the Thompson Center doesn't take a position on these issues, but we are pleased to bring people together to talk about the implications of these sorts of policies and the pros and cons and challenges and opportunities that come with them. We're also pleased here today to have Governor Thompson today from UW System. We're fortunate that in the work that we do at the Thompson Center, we get to work with a number of different UW System campuses. There are 13 in total. And our mission here is the facilitation of research, teaching, outreach, and needed policy reforms regarding effective public leadership that improves the practice of American government. And so in this particular instance, we're partnering with folks at UW-Madison, UW-Whitewater, UW-Stout, and we're pleased to introduce them shortly. Governor Thompson is with us, though, with UW System. He is the president. He's a former HHS secretary, former state lawmaker, and the longest serving governor in the state of Wisconsin. He happens to be our namesake, so we're proud to have him here today, and we appreciate him taking the time. So, Governor?
Eric, thank you very much for that very, very kind introduction, and thank you very much for temporarily leading the Thompson Center. I appreciate that very much. And thank you, panelists, for coming together. It's my honor and privilege to welcome you and congratulate you, and thank you so very much for being involved. You're all wonderful citizens, and you all have a tremendous knowledge base, and I appreciate that very much. The Thompson Center, as Eric has probably told you, is fostering dialogue on as many important subjects that we possibly can take on. And I'm very grateful for the contribution of today's presenters, which are all of you, and for the interest all of you have participated in your lives and what you're doing on your campuses. Let me first say a few words on COVID tracking apps. It's something we have gained some experience here with. We set up a tremendous testing program at the University System, and it's one of the best. In fact, I was just downstairs. We meet every morning from 9:30 to 10:30 on testing across the campuses. And today we have the positivity rate for COVID-19 on all of our campuses is less than 0.1%. We have a total on all of our campuses. We have 4 positive cases on all the 12 campuses. We have 10 positive cases in Madison. So a total of a 0.1%, tremendous. And one of the biggest challenges, of course, of the pandemic on the UW campus is that many people were unknowingly infected. And this is something that we were very concerned about. And we're spreading the virus. And of course, if you all know about it, we had to close down 3 campuses for 2 weeks each time, Madison, La Crosse, and River Falls. But since then, in the early part of October, we haven't had any closures of any of our campuses, and all of our campuses are going to be graduating students in a couple of weeks, and I'm very proud of that. Our testing program throughout the UW system has been critically important, I think, to making our University of Wisconsin campuses safe. I would say that, and I've said this publicly, that the safest place if you want to be guaranteed good health is being on a University of Wisconsin campus. It's really good, and I'm very happy about that. UW-Madison has a Safe Badgers app, and this is something that a lot of you are going to be talking about. And I've got one in my back pocket, and I'm green to go because I got vaccinated. And now, if you get vaccinated, you don't have to go through and spit in the garbage can, which is what you have to go through. If any of you have been through our testing program on the Madison campus, it's not the most delicate way to get tested. I can see some of you nodding in the affirmative, so you probably have been tested and going through it. But if you get vaccinated, and we have a real pushback right now on our campuses with vaccination. We discussed testing and vaccination, and one of the biggest problems are students don't want to get sick during finals, and they're afraid they might have some reaction to the vaccine, so they're pushing back. So right now it's not a supply. It used to be a supply issue. Right now we got plenty of supply, and we don't have enough demand for people that want to get vaccinated. Some would say that's a good thing, but I don't think it's a good thing that we don't have our students vaccinated. I was hoping to get all of our students vaccinated before they come back in the fall, and we're going to have a problem. But the UW-Madison Safe Badger app notifies users if they've been in proximity to someone, which I think is very good, who had tested positive. As one might expect, there was a fair amount of concern from students, parents, and lawmakers over privacy issues. And I'm a big privacy advocate, and I'm sure a lot of you are as well. But the data is kept anonymous, and furthermore, users are able to opt out of the notification function if they so desire, taking care of some of the privacy concerns. But naturally, it also limits the effectiveness of the contact tracing effort. So you have to balance that, but overall, it's working quite well. This balancing of public health and civil rights extends well beyond the boundaries of university campuses. Of course, it's an issue I dealt with over the years as a lawmaker, as governor and Health and Human Services Secretary, prior to becoming president of the UW system. I've been very lucky in my life's pursuits. And finding the right balance is always challenging, especially given the stakes in the current public health crisis. And I appreciate today's panelists sharing their insights and expertise on this topic. So again, once again, let me say welcome to the conference, and I hope you find it interesting and very informative. So with that, thank you, Eric, and I'll give it back to you, and thank all of you for participating.
Thank you, Governor. So now I'd like to introduce introduced a few of our co-sponsors today. So I'll hand it off to Holly for starters.
Hey, yeah, thank you for the introduction. It's an honor to be here today with the Thompson Center to co-sponsor this panel discussion and introduce UW-Stout SAROC, Cybersecurity Research Outreach Center. So in 2017, UW-Stout was designated as the National Center of Academic Excellency in Cyber Defense Education by the NSA and the DHS. So what does SAROC do? SAROC promotes awareness, research, and outreach related to the cybersecurity to meet the cybersecurity education, research, and the workforce needs of the state of Wisconsin. So for the past few years, SAROC has hosted multiple hands-on cybersecurity workshops for high school teachers and the community college instructors in the state of Wisconsin. So this afternoon, we are going to host an IoT Cloud hands-on workshop. We welcome you to be there with us. Thank you.
Thank you, Holly. Now, Suzanne.
Thanks, Eric. I'm Suzanne Swift. I'm with the University of Wisconsin School of Computer, Data, and Information Sciences, also known fondly as CEDIS. And CEDIS is thrilled to partner with the Thompson Center today. As some of you may already know, CEDIS was launched just 18 months ago in late 2019, bringing together the computer sciences and statistics departments along with the information school to work at the center of at the intersection of technology and humanity. We really felt like this event reflects the values of both the Thompson Center in CEDIS in understanding how new innovations and technology can both hold the key to solving important human problems, but also present serious challenges that need to be considered and addressed. So just reaffirming that we're so pleased to have the Thompson Center as campus partners. We look forward to further and future partnerships, and most especially learning from the speakers who are here today. Thanks for giving us the opportunity.
Thank you. And Elizabeth?
Yes, good morning. Thank you, Eric. We here in European Studies at the UW-Madison are honored to join you this morning as part of this great series through the Thompson Center. And thanks to Eric and Tia for having made the partnership so easily managed in this past academic year. So we are here today as co-sponsors under the aegis of our Jean Monnet grants, which come through the European Union's Research and Higher Education Granting Program. And we are also meant to be a vector of public diplomacy, as the EU likes to say, on studying the European Union, how it functions as a global actor, and then making that information available to local constituencies like K through 14 communities or law students interested in cybersecurity, et cetera. So we're very grateful to be here today and know that we're going to hear some truly amazing expertise. Thank you.
Thank you. And then finally, we have Brian Dennis, who's not with us here on the panel, but he's the director of the Cybersecurity Center for Business, which is at UW-Whitewater. And we'd like to thank them as well for their support. Now, I appreciate you taking the time to hear from everybody so far. I think it'll give you some context with regard to who is interested in this topic on the campuses around UW system and what their angle is on their interest level. But this is also a public event, so we will have people in the general public here. And so that's something to keep in mind as we discuss what can be a fairly complex topic. So we look forward to hearing about this. With that, I'm going to hand it over to our two moderators. The first is Sam Wosika, who's with UW-Stout as an alumnus today, but he's also a systems engineer at Cisco. And then I'm proud to say we have a research affiliate with the Thompson Center, Dr. Mariétou Ouayogodé, who's with us today. She's the assistant professor of population health sciences at UW-Madison's School of Medicine and Public Health. Thank you.
Thank you so much, Eric. Appreciate it. And thank you to all the panelists and the attendees. We have really been looking forward to today, and I'm so excited that it's here. You know, sitting here in April of 2021, I think we can all kind of agree that 2020 was a long year, right? We were hit with the pandemic, a lot of social issues, and looking at 2021, and we now can kind of see that light at the end of the tunnel, right? With the vaccines rolling out, with some numbers going down, there's finally that hope. And really, you know, COVID-19 struck the United States and the world faster than anyone could have really imagined. It was a time away from loved ones, a disruption to our day-to-day life, and, you know, for some of us, losing friends or loved ones to it. But it was also really an opportunity to learn, to grow our country, our civilization, and our world. And I know everyone on this call is familiar that pandemics are not something that's new to our civilization, unfortunately. SARS, HIV, influenza, just to name a few, over the past 30 years. But there was really one key feature that set COVID-19 apart from all the other pandemics in history, and really set into motion an opportunity for us to work to ensure that another pandemic does not affect us in the way this one did. And that key feature is technology. Technology that we carry around with us, we work from, we take our classes on school from, and for some of us, we even wear with our watches. So while we were all safe at home in quarantine, either watching Netflix, making homemade masks, or baking sourdough bread, because I guess that was the thing. The team of panelists that we have here today were hard at work, innovating, developing, and researching to truly understand how we can leverage technology to limit the spread and impact of COVID-19 and future pandemics. Today in this panel, we will all have the opportunity to learn about what measures have been put into place around using this technology for tracking, the implications of combining personal health data and technology, and truly discover the opportunities and challenges of COVID-19 tracking applications as pandemic control mechanisms. I'm going to hand it off to my amazing co-moderator, Mariétou, to talk through some of the guidelines around the pandemic, how you can get engaged by asking questions, and introduce our first panelist. Thank you.
Thank you, Sam. Thank you. Good morning, and thank you to the audience for investing your time with us today, and to the panel for enlightening us with their knowledge. And so regarding the format for today's panel, to give you an idea about what to expect. So each panelist will have 12 minutes to present, followed by 3 to 5 minutes of brief Q&A session, where we'll just take a question for clarification purposes. After the presentation will all be done, we'll open up the floor to give the audience an opportunity to ask questions to specific panelists or to the entire panel. So we'll start with Professor Lawrence Gostin, then Ms. Elinor Higgins, followed by Mr. Torsten, Kracht, Dr. Saad Omer, and then end with Dr. Baobao Zhang. And if you have any questions, please submit them through the Q&A option, and we'll make sure to ask all of them, well, given the time that we have allotted for this panel. Without further ado, we'll start with Professor Lawrence Gostin. And due to other professional commitment, Professor Gostin will have to leave us shortly after this panel presentation and after his brief Q&A session. Dr. Lawrence Gostin is an honorary LLD and professor and director of the O'Neill for National and Global Health Law at Georgetown University, and he's a professor at Johns Hopkins University and director of the World Health Organization Collaborating Center on Public Health and Human Rights. Professor Gostin is the university professor, which is the Georgetown University's highest academic rank conferred by the university president. And Professor Gostin has been at the center of public policy and law through multiple epidemics from AIDS and SARS to Ebola, MERS, and Zika. He currently works closely with the Biden administration and global institutions like WHO, the World Bank, and Gavi on the COVID-19 response. So Professor Gostin has led major law reform initiatives in the US and has contributed to by writing numerous books on different topics covering global health security, global health law, public health law, and ethics, foundations of global health law and human rights and global health, and the principles of mental health law and practice. So today, Professor Gostin is going to tell us a little bit about digital health passes in the ages of COVID-19, which are the so-called vaccine passport. I'll let Professor Gostin take the floor from here.
Thank you very much, Mariétou. I appreciate this kind introduction, and thank you, Eric, and to the Thompson Center. You've got a sterling reputation. It's an honor to be with you. I've written both, and I've written an article in JAMA on tracking apps, as well as one on so-called vaccine passports. On the tracking apps, I won't have time to discuss them both. I'm going to focus mostly on the so-called vaccine passports, but it's important to say that with these tracking applications is they have wide variability, and their design features are extraordinarily different in different parts of the world between, say, China, the European Union, UK, US, and also as they were put out in Singapore, Taiwan, and places like Japan. So you need to be very careful about the design features when you're thinking about the privacy and other civil liberties aspects of those tracking apps. On vaccine passports are kind of not, they're the popular term, they're not a very good term. I, in my colleagues in the JAMA article, prefer to call it a digital health pass, or really a vaccine certificate, which I think is a closer fit to this. So what is a digital health pass or a vaccine passport? It's nothing more than the ability and the requirement to show proof of vaccination as a condition of entry into certain high-risk public accommodations, like travel, going back to work, a sports stadium. Globally, there's been a great deal of discussion about digital tracking apps. France just announced a couple of days ago that it was going to launch one for flights between France and French territories, but they're planning on widening it to travel within China and maybe the European Union, and within France, not China, the European Union, and Israel's Green Pass, for example, has really got it back to near normal in record time, where it's used as a QV code on your smartphone, as is the European Union, as is the French app that gets you into various locations, and Israel uses it quite widely for entry into a number of locations. So what I want to do is so that's what it is. It's something more than a way to verify and prove the authenticity of a vaccine or a test result, and the ability to show that in a secure form for entry into certain purposes. So let me just talk a little bit about the ethics of it, and then where I see it playing a role in the United States. I think that might be helpful because I've already talked a little bit about international, including most foreign carriers are considering vaccine passports, but US carriers are not thus far. So the ethics, there's been a lot of controversy about the liberty part of it and the autonomy part. I don't really buy that as an ethical claim, particularly because I think it's absolutely an ethical imperative that every individual has the right to control their own body, to make decisions about their own health and well-being. But they don't have the right to expose other people to potentially dangerous infections. And so you don't have a right to go into a crowded indoor public space unvaccinated and unmasked. That's not your right. It may be your right to make decisions about your own health, but not the health of others. Privacy has been an issue that's long discussed. In our JAMA article, we actually think that digital health passes might, if properly used, could be privacy protective rather than privacy invasive, because done right, they're secure, they're authentic. They only carry information about whether or not you've been vaccinated or tested. You can opt out of that system if you want to. And it doesn't require you to disclose any other personal medical information or any other disability-related information. And so the privacy implications don't, to me, loom large, neither do the liberty ones. But I do believe that there's a very fundamental ethical concern that I have with digital health passes, and that's equity. I don't believe it's ethical to give privilege to the already privileged and to leave others behind. And so as long as you acquire proof of a vaccination, but a person doesn't have access to the vaccine, to me, that's unethical. But once everybody who wants a vaccine can get a vaccine, and we're getting to that point fairly soon, and I'm not just talking about the vaccine hesitant, I'm talking about people, even with enough supply, who really can't access it. They may be homebound, they may be in a rural community, they may be poor, and they just they may have to go to work. So there's a lot of reasons, but if we can deal with the problem of fairness and equity, it seems to me to be reasonable to have digital health passes to just help us to do what we all yearn for so much. We don't want to be sitting at home lonely making sourdough bread. I've tried it. I love bread making. It's one of my favorite things, and I still do it. but we want to get back. We want to hug our family and our friends. We want to dine out with our friends and enjoy ourselves. We want to fly to see our grandchildren and our other dear friends and family members. And digital health passes help get us on that road just a little bit quicker and more secure. So where are we headed in the United States? President Biden has already said that the federal government has no intention to require or implement a digital health pass or a vaccine passport. I understand that politically, but I also think that it would be a great shame if the federal government just stepped back. Instead, I think it should give scientific and technical guidance to those states and localities and businesses that do want to use this technology. That way we can assure that it's done in the right way and in a fair way, in a privacy protective way, in a secure way. We've seen what happens before when the federal government just butts out and leaves it to the private sector and the states. You get chaos. And so I don't think the federal government can or should introduce these so-called vaccine passports the way that other countries will. We don't even have a national vaccine registry in the United States, as opposed to most high-income countries. But I would like to see them give guidance. At the state level, states have been mostly hesitant to launch these kinds of systems. And some states like Texas and Florida, the governors have come out against them. I understand that in Wisconsin, it's highly controversial. And so it may not be, the states certainly have the power to do it, just like they have the power to mandate childhood vaccinations in school. All of us already have a vaccine passport, so-called, a vaccine certificate. It's our school registration, or if we went to a dorm at college, we had to get vaccinated, and there's proof of that vaccination. The major action in the US will be the private sector. Already, many colleges and universities are saying they're going to require vaccinations as a condition of return to school and return to campus life. Georgetown has announced that, as so has many other universities, and I expect more too. The private sector is already considering it, and most CEOs, when polled, say that they would like to implement some kind of an authentication of proof of vaccination for return to work. The Equal Employment Opportunities Commission has put out guidance specifically saying that the private sector has the right and the power to do it, so long as it provides medical exemptions and narrow religious exemptions. So in summary, I think that there are some scientific and technological problems, obstacles in our way. I didn't get a chance to talk about those, but I'd be happy to. There are also scientific ones about how long the durability of the immunity lasts for a vaccine and the variability of vaccine effectiveness across different vaccine technologies. But there are also ethical concerns. And to me, the primary ethical concern is one of equity and fairness. And so I'm happy to stop there. I've studied this issue quite a bit, and if there are any questions, I'd be happy to answer them. Otherwise, I'll very happily just turn it over to the rest of this distinguished panel.
So thank you, Dr. Gostin. We have actually a couple of questions, but we will take one. So the first one says, considering the current trends in data privacy with major punitive laws in the EU and the rollout of the CCPA in the state of California, not to mention older laws like HIPAA, do you foresee further law changes, and in what direction with regards to location tracking, data analytics, also considering that health-related data is now a prime target for Black Hat actors?
Well, that's a very excellent question. I'm going to widen it out a little bit. The implication is that there are a lot of different privacy rules, and do they get in the way of so-called digital health passes? There's the EU Privacy Directive, the California, the HIPAA rule, and things like that. By and large, I think if done right, these digital health passes can be put out without violating US privacy law. We've explained that in the JAMA article, mostly because it's voluntary and you just wait, you agree to it. But secondly, it's for a public health purpose only, and there's a public health carve out in HIPAA. The European Union is much more privacy protective even than we are, and France has already rolled this out, and the EU is considering an EU-wide rollout of some kind of digital health pass. So I think we're in good shape there. I can foresee that we will want to think through our privacy laws going forward, particularly with respect to so-called contact tracing or digital location apps. I think the US and most Western economies were taken by surprise by this, other than in closed systems like the University of Wisconsin system, where it did use a location tracking app, and some Google and Apple applications. It didn't really work out well in the United States, whereas it played a big part in the COVID response in other high-performing countries like Japan and Taiwan and Singapore and even China, but in different ways. So I think going forward, we will want to look at our privacy laws and figure out how we can use technology in ways that are privacy protective, but also protective of the public health. This is an excellent question. That's something we do need to study.
Well said. Well said. I think we have one more question here that we'll ask if you have the time, Lawrence. So a question came in all around equity, and I think you hit it perfectly, just saying how important equity is as we're looking across the vaccine rollouts. But the question reads, how does equity and access to technology and the ability to have devices required to show digital health pass, like a smartphone, come into play?
Yeah. I've done a lot of TV and writing on digital health passes, and I got just somebody from the Midwest just wrote to me, found my email and said, I don't have a smartphone. I've never had a smartphone. What are you slick inner city guys, telling me about, and of course he was absolutely right. And I said that, we do need, we can't have access to privileges of going into ordinary lives only for the tech savvy. That's been a big problem, even in the vaccine rollout, which has caused equity, because the tech savvy educated population has gobbled up, at least until now, the available supply. And so, yeah, we need to find a way somehow that we can authenticate that little white card that you've got and give it, or even use the honor system. I absolutely take that point, and fair go. That's a fair point to make.
So thank you, Dr. Gostin, for all the good exchange here. So we'll move on to the next panelist, and we'll have Ms. Elinor Higgins. And Ms. Elinor Higgins is a research analyst at the National Academy for State Health Policy. And Ms. Higgins joined the National Academy in August 2018 as a research analyst with the population health team. And most recently, her work has focused on the COVID-19 state response, as well as screening and healthy child development, state hospital community benefit policy, and state efforts to advance health equity and address the social determinants of health. Ms. Higgins has a bachelor's from Wellesley College in biology and women's and gender studies. She is currently pursuing an MPH from the University of Southern Maine. And the National Academy and Mathematica partnered to develop an interactive map showing states' different approaches to contact tracing in response to the COVID-19 pandemic. And Ms. Higgins is one of the authors of the research behind the map. and is going to tell us more about the different state approaches to contact tracing. So Ms. Higgins, you can take it from here.
Hi there, thank you so much. And I'm just going to share my screen here. Thank you very much, Mariétou, and I am so happy to be here. As she said, my name is Eleanor Higgins, and I'm a research analyst at the National Academy for State Health Policy. And I'm going to talk about our research and work compiling information on state approaches to contact tracing during the COVID-19 pandemic. And I will talk about trends we've seen in technology use across states toward the end. So the National Academy for State Health Policy, or NASHP, is a nonpartisan, non-member organization that helps leaders lead. So we are supported by an academy of state leaders who are from across the country. They're politically diverse, and they represent many different government agencies. So they help to guide our work. Every year we have a policy conference, and both at that conference and in between, we disseminate solutions and innovations across states to help state leaders learn from one another and come up with solutions to complex health policy problems. So as you may imagine, when the COVID-19 pandemic began, we shifted a lot of our work to focus on the response. And one of the topics that we focused on was the different state approaches to contact tracing. We have all pretty much heard of contact tracing at this point, I think, safely assume, although it's definitely some new terminology for a lot of people, and we've all learned a lot of new words in the past year and a bit. But it is a pretty old strategy used to contain the spread of infectious diseases, and it is a crucial tool that states have been using to try and contain the spread of COVID-19. However, at the beginning of the pandemic, due to chronic, decades-long underfunding of public health departments, there was a mismatch between the existing contact tracing workforce in states and the number of contact tracers needed to make an effective difference in slowing the spread of COVID. And states took a wide range of approaches to dealing with that mismatch. And some of them were around getting their workforce up to speed to get the kind of numbers that they needed to actually carry out these programs. But some of that rested on technology and trying to use technology to fill in some of the gaps in that workforce. So in collaboration with Mathematica, NASHP created a tracking tool where every month we update this website to capture what states are doing in their contact tracing programs. It's sourced from publicly available information, so we wanted it to be a quick tool that we could update frequently, as opposed to something that would require surveying states. So that means it's populated using state websites, press releases, and news articles to kind of keep on top of what's going on in states' contact tracing programs. This map that you're seeing is sort of the homepage, and it shows some of the different approaches that states took to get up to the workforce numbers that they needed, right? It shows different models for taking on contact tracing. So states in orange, they kept contact tracing in-house. It was led by the state or by local public health departments, and they would hire as needed or recruit volunteers, et cetera, but keeping that under state control. States in yellow contracted out their contact tracing work, kind of the opposite strategy. They sort of saw that they didn't have the numbers in-house in the state and instead contracted out. So Massachusetts has a contract with Partners in Health, and they've been leading the contact tracing efforts there as well as in other states. And the states in green are somewhere in between, with states still being, or state or local government officials still leading the effort, but having contracts in place maybe with universities to develop some trainings for contact tracing, or with call centers to provide some of the staff, and have some of these more partnership relationships to facilitate contact tracing. But even with the appropriate workforce, many states turned to some technology solutions to try and fill in some of those gaps as well. So, and I'm going to kind of be giving you a broad overview of these. And I know that some of the panelists after me will get into some more details about perhaps what kind of things worked and what didn't and why. But we certainly saw states turning to phone applications and exposure notification as one strategy. And in the beginning, many states were developing these independently with independent contractors or maybe even startups developing these applications. But they all mostly hinge around Bluetooth technology. So one example is Colorado's exposure notification system, which alerts users to COVID-19 exposure and delivers instructions on how to isolate. In some states, those instructions on how to isolate might include things like resources to support your quarantine, such as how to access food and other kinds of resources like that. But I'll get into that a little bit more on the next slide. Another element of technology in the contact tracing programs was online symptom tracking to help states keep an eye on where outbreaks were occurring and the severity of symptoms people were experiencing. So in Georgia, for example, contact tracers, once they reached a contact on the phone, would ask them to log symptoms in their online monitoring system so that they could monitor for outbreaks that way as well. And then social media was another tool, both to spread information about perhaps what phone numbers to look out for contact tracing purposes so that people would actually pick up their phone. And also in Alaska, for example, social media was used to actually facilitate the contact tracing process to help find and communicate with contacts. And throughout throughout the course of the pandemic and our updates of this online tool, we've been looking at trends in many aspects of the contact tracing response, trends in how states are dealing with spikes in cases or how they're training their workforce, how they're hiring, et cetera. But these are some of the trends we've seen in technology use. So like I said before, some of the early exposure notification apps were developed independently, but increasingly we've seen a trend toward using the Google and Apple technology exposure notification system developed specifically to facilitate contact tracing, and more states have adopted that in their exposure notification apps over time. And those sort of commonalities around technology have allowed for innovations like the National Key Server, which I will not pretend to understand the inner mechanisms of, but it essentially allows those contact tracing apps to work across state lines. And for somebody with that Colorado app, let's say, to go to another state participating in the key server and still have their app work and let them know if they've been exposed. And then one of the other trends, which of course I think we're all going to discuss, are concerns around privacy and data security. So those concerns have in some ways stymied the progress of these apps in terms of how helpful they've been able to be, because if people don't trust them, they're not going to use them. And privacy has been a concern throughout the contact tracing program, not just with technology, but just in terms of being willing to share contacts with contact tracers more generally. So if someone calls you on the phone, you might not want to say something that would cause a friend or relative to have to miss work or so on, or you might not want people to know that you exposed them. And so concerns around privacy have been prevalent throughout this process, particularly around technology. And we can see that reflected in the current legislative sessions this year, with many states, like California was mentioned, bringing forward bills that sort of tighten up some of those privacy concerns. So one example of that is Alabama's Senate Bill 1, which has not passed yet, but has just crossed over from their House to their Senate. And that would make participation in contact tracing voluntary. And it would also tighten up some data security and privacy concerns as well. So NASHP is keeping an eye on those pieces of legislation to see how they're going to impact the response. I wanted to share some additional resources as well. We've been writing blogs about trends we've seen throughout the course of the pandemic. And we also have, as an organization, a COVID-19 State Action Center, where we have not just our work on contact tracing and so forth, but also many other pieces that have to do with many different aspects of the COVID-19 pandemic, and most recently, information about the vaccination rollout efforts, and in particular, how those are interacting with different parts of the response, like contact tracing. So, for example, in Oregon, they were set to release a COVID-19 exposure notification app to help with contact tracing in April, and at the last second decided not to and diverted those resources toward the vaccine rollout. So I think understanding how contact tracing and technology versus vaccines, and perhaps thinking about technologies like vaccine passports, how those things interact, because at the end of the day, there are limited resources to go around, and states are trying to figure out the best paths forward to keep people safe. And then I did also want to flag that in collaboration with Mathematica, we have a podcast that helps walk through our tool and talk about how it came to be, as well as giving some more information about contact tracing and how it adds to the response. And thank you very much. It's been a pleasure speaking to you all, and I would love to take questions if you have any.
Thank you, Eleanor. Extremely enlightening. Just so nice to actually see kind of that map view for us to all understand how different states made different decisions during this. We did have a question come in around the map, and as far as the effectiveness of leaving contact tracing up to the state versus partnering versus contracting it out, did you all collect any data kind of regarding how well these different approaches were working?
That question, the question of what works, is truly the magic question, and it's what everybody wants to know. And I think that we're all going to be doing some, I suppose you could call it like post-game analysis on that for a long time after this. We're actually anticipating doing some of that work coming up. I guess I don't have anything concrete to say about that, except for to tell you what the trends are that we've seen. So I think you could see on the map that the majority of states were partnering in some way. The majority of states were shaded in green. And that is not how it looked at the beginning of the pandemic. So early on, more states were doing that work in-house, and we're trying to hire and do it all sort of under the state government or local government umbrella. And that has changed more and more to include new partnerships. So I can't say for sure whether that means that that's more effective, but it definitely seems to be the way states have been moving, and we can kind of draw our own conclusions from that to think that perhaps that means that partnering, at least for some aspects of training or simply ramping up workforce, is more effective.
Awesome. Thank you, Eleanor. That makes a lot of sense. And then one more, you were talking through Google and Apple, and a lot of those kind of Silicon Valley-based technical companies did get involved. And would just kind of like your thoughts as far as, should they be the ones working to drive this, as they, are the leaders, the developers, and the makers of these technology devices?
It's hard to know, and I think we're going to see, we're in some ways we're seeing how much people do trust those actors. I think like that's sort of what the laws that have come up, or the bills that have come up in state legislatures this year are showing us, is that there's in some ways some backlash to that, some sort of saying, I don't know if we do trust them to be keeping our information safe, whether that's fair or not. And I also think that in some ways, I think we all know that states were very much left to their own devices to come up with their own approaches in this pandemic, and perhaps the sort of absence of like federal leadership in some ways on those topics left room for different actors to kind of have more of a role than they might have otherwise. So I think there's a few different reasons why that happened, and whether or not they should is certainly not up to me, but I definitely think we're seeing some responses from the public about how they feel about that and how much they trust sort of Silicon Valley and private companies versus more public sector actors.
Great, thank you, Eleanor. In the interest of time, we'll move to the next panelists, who is Mr. Torsten Kracht, and he's a litigation partner in the District of Columbia and New York offices of Hunton, Andrews, Kurth, and he represents clients from the U.S. and abroad in complex commercial litigation and arbitration. Mr. Kracht has served as trial counsel and jury and bench trials in various jurisdictions and as arbitration counsel in the American Arbitration Association, the National Association of Securities Dealers, and the International Chamber of Commerce proceedings. He has particular experience counseling clients on litigation strategies that effectively balance legal risk and business goals. Mr. Kracht is a co-author of the COVID-19 complaint tracker, and the COVID-19 complaint tracker that he developed consistently receives thousands of page views and has been cited as a resources in the New York Times, the Wall Street Journal, Fox News, CBS News, the Washington Post, Forbes, and Associated Press, and has been recognized as an innovative legal tool by the Financial Times. He also received the 2020 District of Columbia Litigation Trailblazer Awards and National Crisis Management Award from the National Law Journal for his work on the tracker. So Mr. Kracht has also spoken at numerous events concerning the tracker and the litigation statistics related to COVID-19, including at events hosted by the U.S. Chamber of Commerce Foundation and the Virginia State Bar Association. And he's going to tell us a little bit more about the landscape of COVID-19 legal complaints today.
Thanks, Mariétou. I appreciate it. And thanks very much to the Thompson Center and to Eric. It's a great honor to be able to share this with you. I'm just going to share my screen quickly. So at the expense of my sourdough baking skills, I've been working on this COVID litigation tracker for the last year. I hope you all can see that. Mariétou, if you can give me a thumbs up if you can see it, that'd be great. Okay, terrific. So the genesis of this tracker was when I saw that COVID-19 infections were spreading rapidly and were coming over to the United States. As a litigator, I started thinking about what kind of legal cases we would be seeing in the United States that were related to COVID-19. And my immediate thought centered around a legal doctrine called force majeure. And for the non-lawyers in the audience, force majeure essentially it may be familiar to you as something called an act of God. And it's a principle that excuses a party from performing under a contract if something happens that prevents their performance that's totally out of their control. And so normally you see that in situations like natural disasters, earthquakes, or hurricanes, where one party can't deliver goods to another because there's no physical way to get the goods there, and nobody had anticipated that event would occur when they were making their contract. And so in my mind, that would become an important legal issue related to COVID-19. And so I did some research to see how that issue had been addressed in prior pandemics, and there was no case law on it for the last 100+ years. Last time there was a case on it, it related to a cholera outbreak up in Maine. And so I became interested in tracking all of the cases that would be hitting the courts on this force majeure issue in the United States as COVID-19 spread across the country. And working with some technology folks at our firm, we figured out that it was going to be just as easy to track all cases related to COVID-19 as it was just the force majeure cases. And so that was the genesis for this COVID-19 complaint tracker. And I think we launched it probably in late March, so after the pandemic designation had been issued. And we've been running it ever since. And it's a very comprehensive database of all the state and federal cases that are filed in the United States. On the federal side, that's a relatively easy thing to do because the federal courts have an excellent system of public access to filings, and it's updated continuously. It's always current. And then as you get into some states and municipalities, the resources for having updated public access start to dwindle. And in some cases, you literally have to go into the courthouse and pull complaints by hand to try to figure out what they're related to. But we've got a pretty comprehensive database of all of that. It refreshes every single night on a live feed. And we probably will keep running it for as long as COVID-19 remains relevant and the cases remain in the system, which I imagine is going to be for many, many years to come. Even if we reach herd immunity, the legal ramifications of COVID-19 on the economy and on society have been massive. So I know we're running a little short on time, so what I'd like to do is just run you through some portions of the tracker. Now, this tracker is publicly available. We host it on our website as a public service. It's been used by government authorities, media outlets, academia, clients, of course, who are interested in litigation trends, but everybody's welcome to use it. I don't know if you can see my URL on top of the screen here, but the easiest way to find it is just to Google Hunton, H-U-N-T-O-N, COVID-19 tracker, and this should come up as the first search result. So basically what we built is a relational database of all the cases, and then this front end is built with Microsoft Power BI, which many of you may be familiar with. And we keep a running total of all the cases filed to date. You'll see that's around 10,000 up here. You can drill down into date ranges by sliding this bar in either direction. And you can see which states are in the top categories in terms of number of cases filed. And so you've, not surprisingly, got some of the high density population states that appear at the top of the list. Sorry, I just need to move something out of the way here. Then as you scroll down in the tracker, here you see sort of the running rate of all cases that were filed. And interestingly, the first case in the United States was back in January of 2020, well before the infections really were widespread here. And that was a case by a group of airline pilots against their airline. They were trying to petition not to have to fly routes into certain areas of China that had already experienced very widespread infection. And then you see really in March, the pandemic designation was on March 11th. And then, March, it really starts to ramp up in terms of cases filed. And then sort of in April of 2020, we're off to the races. And there are cases being filed at a rate of, 25, 50, 100 a day sometimes. Just a couple of really interesting trends that we saw in the data. And you can, when you access this, you can drill down into all these different categories to really understand with more detail what types of cases were being filed. But initially in this period, a lot of the cases that we saw were habeas corpus petitions, or petitions by prisoners or other incarcerated people who were trying to be released from incarceration for fear of being infected. And oftentimes they had an argument about underlying conditions and the great risk that they would be placed under if they were to continue to be held in incarceration. That made up a huge chunk of the early cases. Later on, as we got into the year, we saw an interesting trend. It was an election year, of course. We saw a lot of election-related cases. And so those normally would have been challenges either to changes to the election process to accommodate COVID-19 and public safety, or failure to make those kind of changes. And maybe those ran along party lines, maybe they didn't, I don't know. As we got further down into 2020, what emerged as the biggest category, hands down, were insurance-related cases. And those were cases where businesses who had business interruption insurance were making claims against their carriers for the losses that they incurred while they were out of business. And those kind of cases continue to this day to be very robust. Now, two types of cases that we didn't see a lot of action in, where we thought we were going to see more. The first one was what I predicted, which were the force majeure cases. And much to my surprise and embarrassment, there were 83 cases in total in that category that have been filed to date. So that was a big sort of letdown to see how small that number was comparatively. My prediction was completely wrong. The other category that received a lot of attention was the category of personal injury and wrongful death cases. And there was a lot of attention paid by the media to these areas, in particular because states were considering COVID shield litigation that would limit the amount of liability that businesses, for example, would have if somebody got sick in their establishment. The number of cases that were anticipated early on didn't materialize early on. And there are probably a few reasons for that we can talk about in the Q&A if anybody's interested in it. But one of the primary primary issues there was that if you had people working, for example, and getting sick on the job, they normally would go through a workers' compensation insurance system rather than filing in court. And there were a number of other reasons as well. So that's the highlight of the tracker. All of these bits of data, if you're familiar with Power BI, are interactive and everything changes. For example, if you touch on the state of Florida, you'll see all of the other portions of the summary statistics reflect only Florida. And you can always come back out to the main screen just by going to this button here. We do have a detailed data section. This is a little more raw data from our underlying relational database. This is password protected because it contains some licensed content. And so this is really reserved for our clients and certain other limited groups. But otherwise, the rest of this is all publicly available on the internet.
Thanks, Torsten, for this nice presentation. So I have a question regarding, so if you can scroll up to the map. So we can see here that there is variation across states and I guess regions as well. So with a couple of states, including Wisconsin and other neighboring states, Iowa and Indiana, and others that where the state mask requirement mandate is has expired or was lifted, should we expect to see more employment-related lawsuits against businesses or even other type of lawsuits based on your experience with the tracker?
In jurisdictions where the mask mandates are being lifted?
Yes.
Yeah, you know, hard to say. On the employment side, probably not, because in employment cases you have workers' compensation insurance that usually is a barrier to filing a lawsuit, and workers' compensation claims aren't public in the same way that lawsuits are public. So I wouldn't be able to easily know that by looking at the complaint tracker, whether the number of lawsuits are going up or not. What I think you may see in states that are rolling off of mask mandates or are considering it are upticks in a category that we call civil rights, which is down here. And one of our subcategories in civil rights are business closures, stay-at-home orders, group gathering bans, and other public safety measures. And those are things that you could easily see more activity in. And you'll see here, for example, in March of 2021, I'm just drilled down into this public safety measures category. There was a little spike in March of 2021 when some of these mask issues were coming to the forefront. And if we drill down into the business closure, it's the same thing. You see a little bit of a spike here in March 2021. So I guess the short answer is probably, but not necessarily brought by employees against their employers.
Awesome, thank you, Torsten. I think it's good to look at this, not only the map here, but also this side of litigation, right? It's, at least for me, not something I've ever really thought about during this past year, and just how big of a portion this is. And that really brings up this question that someone sent in, and it's this pandemic has brought the idea of public health to a lot more people's attention. Do you think that this will lead to an increase in public health complaints related to health issues other than COVID-19?
Yeah, I wouldn't be surprised at all if we did see more litigation, right? It may have been you, somebody said earlier that this is sort of the template for the next public health crisis, right? In how we use technology. And I think likewise in the legal landscape, this is going to be a template for how we approach the next pandemic or other public health crisis, where people will see what sort of legal tools worked and didn't work during the last one, and they'll act accordingly.
So, you know, if I can ask this question, and you definitely don't have to answer it, but what have you personally learned from this COVID-19 pandemic and, you know, dealing with these litigations? And if this were to come again, how would you work to position yourself differently?
So if I understand the question correctly, sort of what have some personal experiences been in the litigation front related to this?
Yeah.
Okay. So I'll give you an example just from my force majeure topic, where I was the big loser in what I predicted, right? And what I found in working with clients was there were actually a lot of instances where force majeure came into play between them and their contract partners. In the pandemic affected oftentimes both sides of a transaction, both partners in the transaction, not just one. And, for example, if you had a contract to supply ethanol, right? The inputs of ethanol are corn, and then it's fermented, and the output is ethanol and grain feed. So oftentimes, if you're supplying ethanol, you're also supplying grain feed to somebody else. Now, when the pandemic hit, you couldn't put gasoline or ethanol anywhere in any storage facility because it was backed up. Nobody wanted it anymore. And so that affected some downstream contracts for either buying corn or for producing feed. And so you had a lot of these examples where parties were constrained by the pandemic. Force majeure was a real issue. But what I found very heartening was, as a lawyer, that more often than not, parties were very willing to come together and work out a consensual solution rather than running into court and suing each other. And I think there was a lot of really positive movement in the economy and in the business community that was very cooperative, which was really heartening to see. Not so great for the business of a litigator, but very heartening to see.
Thanks, Torsten. So we'll move to the next panelist. And so we'll have Dr. Saad Omer. Professor Saad Omer is the director of the Yale Institute for Global Health and a professor of medicine and epidemiology at Yale University Schools of Medicine and Public Health. He has conducted studies in the United States, Guatemala, Kenya, Uganda, Ethiopia, India, Pakistan, Bangladesh, and South Africa. Dr. Omer's research portfolio includes epidemiology of respiratory viruses such as influenza, respiratory syncytial virus, and more recently COVID-19. Clinical tries to estimate efficacy of maternal and/or infant influenza, pertussis, polio, measles, and pneumococcal vaccines, and trials to evaluate drug regimens to reduce mother-to-child transmission of HIV. He also published over 340 papers in peer-reviewed journals and has mentored over 100 junior faculty, clinical and research postdoctoral fellows and PhDs and other graduate students at Yale. And so Dr. Omer will tell us a little bit more about social contact patterns during the COVID-19 pandemic.
Great, thank you. It's my privilege to be here, and it's an honor to be sort of presenting and talking about some of these issues here. So a little bit of an anecdote. Governor Thompson has had a lot of impact on public health leadership, and my sort of contact with his influence at HHS has been through colleagues, career colleagues that have continued to work there, that I collaborate and interact with some frequency. And it's not rare for things to come up in conversation that include lessons in leadership from Governor Thompson. And so it is very interesting to note that it's been a while since he left. HHS, it was in 2005. Given that it was a senior leadership position, I can only imagine that his career started at the age of 12. But I think academia is well served by folks with real world experience that is respected broadly in a bipartisan fashion. And I think we need a lot of that in this kind of pandemic, et cetera, where things can be forward-looking, evidence-based, and then that we can all agree on. Coming back to my topic, I'll be discussing a few of our papers, and I won't present slides. I'll do this old school. And there are several projects we have been doing in this pandemic, but I'll highlight 3-4 of those. The first one is that we earlier on realized in March, a little over a year ago, that there will be drastic changes in mobility in this country and throughout the world. So we did a study to look at, we got data by actually being in touch with the CEO of this company, City Mapper, where you can map your trips both through public transportation and your own transportation. So it combined that, and so we wanted to look at mobility. Are some of these policy changes, are they actually having an impact? So ours was one of the earliest forms of data, and so that have some lessons too in terms of, as you do these tracking apps, how people move and what is the voluntary response. Then we did a study that looked at it more rigorously in terms of teasing out the impact of the policy interventions like stay-at-home orders and voluntary response. So because both of these things are important, we are not going to have, at any time soon, shelter in place and that kind of orders going forward. There may be limited sort of public health restrictions that may go up and down, but it is important to tease out what was the component of the voluntary response versus policy-induced response. So we had that paper come out, the Proceedings of National Academies of Science. Actually, a few weeks ago, we had a preprint out since summer looking at that issue. Then we have had a series of projects from before the pandemic, where we highlighted, for pandemics. Of course, a lot of us have been working on these issues before, this current pandemic. And one of the things we identified as a group of some of us at Yale and Emory University, where we figured out that there was very limited data on people's contact with each other. Well before these tracking apps were even sort of required. And so we wanted to collect high quality data, but also data that includes qualitative data in terms of why people interact. And so we had a series of projects and two sister projects that I would highlight. One is a domestic project in US companies. And again, this was proposed and was approved and funded by the CDC before the pandemic. We actually implemented it during the pandemic because of the timeline. The other one is an NIH-funded project, which is based in 8 locations in 4 countries, urban and rural locations. So in low and middle income countries, that's even more, there are huge data gaps in terms of how people interact. So the tools we use are contact diaries. And then as people come back, we'll be using RFID sensors. There's a third project there, which I'll briefly mention, which is ongoing, that we're doing the similar thing in healthcare settings, et cetera. So that's in a nutshell that in terms of how we are doing it. So now a little bit of data. So we identified, obviously in the absence of any pharmaceutical intervention, one approach is reducing contact rate. And even in the context where you have vaccines available, you have a dimmer switch kind of an approach, because unless everyone is vaccinated and you have sort of sustainably controlled the outbreak. And so in early March, a lot of governments over the world instituted different measures to increase social distancing. But at that time, the information of their effectiveness in reducing mobility, this was before Google started tracking mobility, so it was lacking. So we analyzed in March of 2020 the mobility data from 41 cities around the world to look at the effects of these interventions. So first of all, we found that on March 2nd, 2020, there was 100% of their baseline, so what was expected using Citymapper data. But then it decreased to a median of 10% of the usual mobility on March 26, 2020. And then we also found that the mobility decrease, and as sort of measured by people's planned and taken trips, both through public transportation and through their own transportation, we found that this mobility decreased on average by 3.4% per day between March 20 through March 26. And then what we also said that we also looked at we also found the initial evidence that cities that had social distancing measures, shelter in place, or I don't like the term lockdown because there's more nuance to it. They were also sort of having an impact, but there was a strong behavior, voluntary component to this. And so our study provided initial evidence, one of the earliest evidence of reduction in mobility in cities that were instituting various measures, or they were anticipating these outbreaks. Then came sort of our study where we try to isolate that the policy responses and the impact of policy responses and voluntary responses more directly. And this time it wasn't mobility, it was stay at home. So it's a different thing. You could be elsewhere as well, but stay at home is more in line with recommendation. You could have mobility through other indices, and you could do it safely. People figured out ways, for example, of traveling in small groups without increasing their exposure. But so therefore, in this study, we looked at sort of national data from the US using cell phone data, anonymized cell phone data, that we found, what was the impact of the voluntary component versus the policy component. So we found that evidence that stay-at-home orders and voluntary response to locally reported COVID-19 cases led to behavioral change. So it is important to know that folks responded to how much cases were there. It was very strong. So we had multiple specifications of our model, but essentially people were responding to how much disease was there, and especially how much death was there in the community for modifying their behavior. So that was a voluntary response component. And here was a nuance that in rural communities, it was more local response, so responding to what is happening locally. And in urban communities, it was actually a national response to what is happening nationally. So that was an interesting point, because, and we think it works through a behavioral mechanism of availability heuristic, where sort of people judge the probability of an event and risk of an event based on how, the probability of an instance that comes to their mind. So that depends on coverage, et cetera, and their awareness of it, not just the objective number of cases. And so we also figured out, okay, so how much of that voluntary response can we calibrate as a unit? What would be the county level cases that would be needed to induce the same voluntary response that was implemented by stay-at-home orders? So what we found was that on average, an average county in the US implemented these orders at 2 cases. And for us to have a voluntary response, those counties to have a voluntary response that matched the impact of these stay-at-home orders in terms of people's stay-at-home behavior, they would have needed many times more cases, so around 29 cases versus 2 cases. So thinking from that perspective, we found that both were true. There was a strong voluntary response, and this was in the initial phase when things were more pure in the sense that there were no vaccines, et cetera. And there is also a substantive stay-at-home response. So it would be, sometimes these discussions are very simplistic when you're looking at mass behavior. They focus on, for example, what is the value of stay-at-home orders? They forget that there is a small policy component, but on the other hand, there was value in stay-at-home orders. It's another debate on how sustainable they are in the long run, et cetera. But from this perspective, there was an impact. And the implications now are that as things open up, that has implications on businesses as well, because of this strong voluntary component. And I'll come back to it in the context of vaccine passports in a second. The next thing that I'll talk about is our what we call the corporate mix study, where we recruited people from US companies to see what was their behavior during during last year's pandemic. And the data were collected from April to June 2020. So there was a lot of action happening in terms of people staying at home, et cetera. And the main outcomes for that study was a medium number of contacts per person per day. And so we had approximately 4,000 employees that were approached, et cetera. And then we had, from them we had sort of recruitment. What we found was that there was a medium number of contact during this period was 2 contacts per respondent on both, on sort of, we collected it on 2 snapshots. The majority of these contacts included conversations only, occurred at home, and cumulatively lasted more than 4 hours. So these are people they're interacting at home. So if, so that has disease control implications. The other thing was that most of these contacts were repeated and were within the same age group for participants 30 through 59, but sort of within the same age groups. However, participants from 30 to 60 approximately reported substantial intergenerational mixing with children. So that's not surprising. So what we found that there are, we found that in that phase, there were very few contacts, but there were household contacts. So in these kinds of phases of the epidemic, often you can't measure at this micro level using the tracking apps, because especially if the household contacts are there, and so the ability to measure, what is happening within the home, because the cell phone itself is not moving, it is important to have these kinds of other data collection activities to complement and supplement tracking app data. Coming to these, the so-called digital instruments that were discussed, or the so-called vaccine passports, I have a little bit of a nuanced view there. I do believe that there are issues in terms of equity and the ethics of this, but unfortunately, whether we like it or not, they are here to come. They're here to stay, or they are coming or have come already. And the reason for this is that private businesses and governments have huge incentives to implement them. And so we have 2 options. We can do a lot of hand-wringing, or we can try to make them as equitable, as efficient, and as effective as possible in, from that perspective. And then there are a few thoughts around this. First of all, I absolutely agree that, without access to vaccines and true access to vaccines, it is inappropriate and outright unethical to sort of restrict people's ability to move around in the society, or not restrict, it's not restricting, but to implement these kinds of tools more broadly. But in the US, we are reaching a phase where largely the vaccine supply and access will be there. Although it's not perfect, we have, at the end of the day, a fragmented healthcare system. But my concern is that, if we don't do something rational about these kinds of approaches to verify people's vaccination status, companies have, I'll give you an example. What do you do when a cruise ship company wants to open up and they want to mitigate the risk of outbreaks? Businesses, large and small, have been suffering. We can't be just naive and say that that shouldn't happen. It will happen. What happens when foreign countries, for our travelers, for essential and even, so frankly, leisure travel, one person's leisure travel is someone else's job, implement these kinds of requirements? Do you sort of take a stand against the Saudis to say that they are opening up the Hajj, where people from all around the world mix, and they have this kind of vaccine requirements? They can't shut down the Hajj second time in the row. Last year was the first time they did it in history, and they will have political ramification if they do it again, frankly. And so you can't. We will have to have a nuanced. We will have to have a harm reduction approach to this, to say that there are certain basic services where we can never have these kinds of things because it will impact people's ability to access these kinds of services. But on the other hand, for example, clinical care, or other types of basic functions. But then there would be, other nuances that we need to figure out in terms of traveling during rush hour versus out of rush hour, where you're not taking people's ability to move around through public transportation, perhaps, but your ability to sort of add more nuance to these kinds of situations. and what is the limit of the private businesses to use these kinds of requirements. So we may or may not like them. They're here to stay, and we need to, or stay in the next few months. They're already here, but we need to figure out equitable and efficient and effective ways of implementing them. The other thing that is missing from a lot of this conversation is not just equity, is liberty. And any considerations of passport is not just based on access, but the self-efficacy people have and people feel in terms of their ability to perform basic social functions. There's a very there's a subtle difference in between the equity framing and the liberty framing, but it's equally important. If we don't pay attention to this as a society, then it's going to create unnecessary fissures in any policy going forward to control this outbreak more sustainably. Because what we are looking at right now, based on the slowing demand, people will continue to get vaccinated. The slope will taper off a little bit in this country. And so the situation will be, there will be people who will be protected, at least in the short run, before a monster variant comes in. Right now, the data look good in terms of severe disease and vaccines being protective. But then we will still see the hampering of social functions due to outbreaks, especially amongst the unvaccinated, and then spilling over, since if there's a high force of infection, spilling over into those who are already vaccinated a little bit through breakthrough infections. So in those kinds of scenarios, there will be an increasing desire to create these islands of safety through these kinds of requirements where people and businesses can exist with the peace of mind.
Thank you so much, Dr. Omer. We have a clarifying question about the different places where you collected data from. Can you tell us a little bit about those different places? I know you mentioned some in the United States and also outside of the United States. So can you please tell us a little bit more about this place?
Yeah, so our first project, where we just purely looked at mobility, the city mapper data was 41 countries around the world. So these are usually large countries like Delhi, New Delhi, Hong Kong, Paris, London, etc. And there were US cities as well, New York, LA, etc. Major cities. That was the first snapshot. Our corporate mix data from companies were exclusively US companies, 3 US companies. And these were companies that we selected were largely that were performing office work under normal circumstances, so they could social distance, etc. The third one, where we looked at the policy response versus voluntary response, these were national sample of cell phone data, anonymized to county level. So we did the analysis at the county level for those data. Those were essentially safe graph data that we used.
Perfect. And then just one more question here that I think we're all curious about. And that is, based on your data before COVID, during COVID, and now coming kind of towards the end of it, does your team have any sort of predictive timelines as far as where we might be based on the data that you're collecting? Totally fine if not. I just thought it was a good question to ask.
So it is from not just this, but other sort of data streams, etc. Look, I think we will have we should see, and we have started seeing a decoupling between mortality and cases in this country. So that's number one. There is a lot of noise in the system saying who should be prioritized, who should not be. But what people don't realize, most states actually implemented the overall strategy, which was initially developed by the National Academies of Science, Engineering, and Medicine in late summer, early fall, before the ACIP, before CDC did its own recommendation on the behest of the CDC and NIH director. And I had the privilege of being part of that sort of group, where it was recommended that irrespective of the priority group, it should be mortality first. So you go after the mortality, not try to interrupt transmission when you have limited doses, then slowly, or not slowly, as your doses become available, then go for transmission interruption approach. So that has happened. So at the later phases, there was a discrepancy between stages, but the initial focus was the elderly, the long-term care facilities, and the healthcare providers. So that has the fact that the differential was crazy high. It wasn't twice or thrice, like we were dealing with 60 times higher risk of mortality. Nobody is without elevated risk of mortality in this pandemic. I should recognize that, but some people are way, way worse off. And so by targeting those groups, we will be decoupling mortality. So in that case, we will find that, states would find it more easy to to relax some restrictions, but also that would because of higher vaccination rates, there will be gaps in testing then, because there are a lot of people who would not be going for testing. So and the testing capacity will there will be less incentive to maintain testing capacity. So we will be flying a little bit partially blind, etc. So that we should keep that in mind. But what we are likely to see coming fall is reduction in mortality, even probably reduction in cases as well as we go up, but outbreaks, flare-ups around, in geographically restricted or social clusters of people. So that could have implications of not being able to come back to total normal, still working under these kinds of situations, but also places that are able to have high vaccination rates, specifically like universities, like other places, being able to function in a way that you are, you're in a little bit of an island surrounded by raging seas, kind of a situation, and we'll see lots of those.
Yeah, thank you, Dr. Omer. We'll definitely be interested in looking at how these patterns in mobility actually translate into mortality and morbidity outcomes. So now we'll move on to the next. So last but not least, we'll have Dr. Baobao Zhang. And Dr. Zhang is a Karlman postdoctoral fellow at Cornell University Department of Government and a research affiliate with the Center for the Governance of Artificial Intelligence at Oxford University. And Dr. Zhang is working in the Department of Government with a secondary affiliation with the Department of Information Science. And in the fall of 2021, she will be joining the faculty at the Maxwell School of Citizenship and Public Affairs at Syracuse University as an assistant professor. And at Maxwell, Dr. Zhang will be working in the Department of Political Science and an affiliate of the Autonomous Systems Policy Institute. So Dr. Zhang's current research focuses on the governance of artificial intelligence. In particular, she studies public and elite opinion toward AI and how the American welfare state could adapt to the increasing automation of labor. And her previous research covered a wide range of topics, including the politics of the US welfare state, attitudes toward climate change, and survey methodology. Dr. Zhang is a co-author of recent work on the American perception of privacy and surveillance in the COVID-19 pandemic, and also another project looking at contact tracing different obstacles. So today she will talk to us about why contact tracing apps were not so successful in the US and what universities have been doing and some of the lessons learned that we can take from this pandemic.
Thank you so much for the introduction, and thank you for for inviting me to speak on this panel. I'm learning so much from the other panelists. I'm going to be quick and I'm going to share my screen because I've made a presentation, and I'm going to try to go to full screen view. Can everyone see it? Thumbs up. So going back to the beginning, talking about digital contact tracing, I will give a short presentation on what I see as sort of a postmortem on why digital contact tracing has not been successful in the US. This is a joint project with the Cornell Tech Policy Lab. I encourage you to check out our website. We have a lot of interesting studies, both on the use of technology in the COVID pandemic, but also on vaccine acceptance and governance of AI. This is a joint project with many members of the Tech Policy Lab, and I want to acknowledge this team effort. So how I got interested in this topic is that I've been seeing expanding public health surveillance. When I go into work, I have to do a temperature check. Negative COVID-19 test for travel has been something that many of us have done. If you've been to, say, the EU, a lot of my friends had to get negative COVID-19 tests. And we've also seen a proliferation of these things that are colloquially called contact tracing apps. They're sort of known technically as exposure notification apps, and they're sort of a way to supplement manual contact tracing at a time, as Eleanor mentioned, when the contact tracing workforce is overwhelmed. So to give a background on these contact tracing apps, this data might be a bit outdated. This is from when I was guest teaching last week. So 49 countries have introduced or planning to introduce contact tracing apps. The number might have increased in the last week or so. And the majority of these use Bluetooth proximity tracing technology, and only 8 uses GPS location tracking. There's been a study that's widely cited from a group of Oxford researchers that say that if we reach 60% or more of the population using these apps, we can stop the spread of COVID. That is very sort of utopian and optimistic. But I think what's missing from the conversation is that even at lower rates of adoption, you can still reduce infections. Unfortunately, what's happening in the US is that the rate of adoption is just so low that I think we're not really going to see much of effectiveness. As some of the panelists have talked about earlier, Apple and Google have built this Bluetooth proximity exposure notification system, and it uses decentralized data storage. And I think as sort of a public health message, every time I give this presentation, I just want to explain to the audience how it works, because it's just very complicated and not something that we can easily think about in terms of, it's not GPS location tracking where your cell phone tells the database where you are in terms of longitude and latitude. It's quite different. And I think that has also hindered the public's understanding of these apps. So I'm just gonna, with my 2 phones, I'm just gonna quickly walk you through it. So say Andy and Beth, they meet up, their phones, and exchange this anonymous key code. And when Andy becomes infected, he can update his status in the app. So when he gets a positive COVID test, he'll get a code from his health provider that says you can use this to update the app. And he has to consent to update his status in the app. And so his key goes up to this database, and then Beth's phone would regularly download the key codes from this database, and then it would alert her that someone she has been near has tested positive for COVID, but it doesn't tell her that it was Andy. So there is a certain level of privacy that is built into the system. So at that time, when my colleagues and I were writing this paper that has since been published in PLOS ONE, we were interested to see if people's perceptions of privacy and their willingness to accept surveillance would impact how willing they are to accept these contact tracing apps, but also other surveillance measures. And so we conducted a nationally representative survey in the US, and we asked about a number of public health surveillance measures. And what we found across the board is that support for surveillance is relatively low. People are okay with temperature checks or traditional contact tracing, but when it comes to smartphone contact tracing, people were meh, and things like using credit card or debit card transactions to track where people have been, which has been used in South Korea, Americans were like, no, no way, this is too much violation of privacy. And we also see some partisan differences in terms of accepting these measures. Interestingly, it's the independents and not necessarily Republicans who are more opposed to some of these measures. What we found interestingly is that while there is a partisan difference in terms of support for expanding traditional contact tracing, smartphone contact tracing apps, we see less of a partisan difference. And I think that has explained why we haven't seen sort of red states rejecting this technology. It's actually sort of bipartisan in a way that many states, both red states and blue states, have rolled out this technology. So here's just sort of a breakdown by the percentages. Where supporting for government expanding traditional contact tracing, there is more of a partisan difference. There isn't that sort of as much of a difference in terms of smartphone contact tracing apps. Next, we wanted to look at what features of contact tracing apps made them more socially acceptable. At that time when we were doing the study, we were trying to help advise the state governments that were deciding, like, should we use a GPS location tracking, or should we use something like the Apple and Google system that doesn't rely on GPS location tracking? And so we implemented this technique from marketing called conjoint analysis, where we vary different features of a hypothetical app. So a lot of ad agencies would do that if you're trying to buy toothpaste or if you're trying to buy face cream. In a way, you know, we're sort of trying to understand how do we market these apps to the public. And so we varied who's developing the app, whether the name matters, calling it a contact tracing app versus an exposure notification app, the data storage method, whether the data is stored in a central server versus most of the data is stored on your phone. This method also has implications for your user experience. With a decentralized storage method, you can just have the app running in the background. It's not going to drain your phone's battery. You don't have to have your screen unlocked when you're using it, which is bad if you lose your phone, right? Then someone could just steal your phone and hack into your personal data. We wanted to know if people were more willing to adopt it, if there is an explicit expiration date, whether the percentage of smartphone users, that mattered for people's willingness to download the app, and what kind of technology is used. The one thing that we found that is going to increase people's likelihood of downloading and using this app is the decentralized data storage. Everything else doesn't seem to make much of a difference. And that's sort of a 5 percentage point increase, which is statistically significant. But again, as I will mention later, it's sort of at the margins. The decentralized data storage method increased people's confidence that the personal data will be protected. It sort of very marginally increased people's agreement with the statement that the government should require people to use the app. And just to summarize the results of our study, we found that support for public health surveillance measures to curb COVID-19 is relatively low in the US. That's not unexpected. And we found that contact tracing apps that use decentralized data storage compared with those that used centralized data storage were more accepted by the public by 5.4 percentage points. While we observe a greater partisan difference in terms of expanding traditional contact tracing, there was a smaller partisan difference in support for digital contact tracing. So we published our paper, we wrote up our results in a technical report that was cited by the US Senate, and we were really happy to see that most states went with the decentralized data storage method, but this is a forecast of things to come. So here is a graph of the percentage of the population in states that have rolled out these contact tracing apps. There's some that are zero. They're not, I should point out that they're missing data. We don't have data on this. This is data collected by the MIT Tech Review. We're hoping to work with them in the future to get more data. And we've, unfortunately, you know, in most states, its use rates are in the single digits. DC has had some success, but otherwise it's not looking good. Here is another view of this. This is this previous data has been reported by the state public health authorities. This is sort of stuff that you can find online. I went to the Google Play Store to look at download rates. I looked at the Google Play Store because some states have actually decided to automate how it's downloaded on iPhones, the Apple mobile OS method. You don't need to download an app, you can just change something in your setting. Whereas with Android phones, you have to download it from the Google Play Store. So this is sort of a more accurate measure of download rates. Unfortunately, Google doesn't give you the exact number of downloads. They put it in categories. And so here I just sort of mapped out the population percentages on the x-axis and sort of the volume of downloads by these categories. And we sort of see a linear trend, but, you know, California, which is, you know, very populous, it's in the same category as Virginia or Pennsylvania, which have a much smaller population. And if you're looking at sort of an international comparison with England and Wales, they're in the 10 million download category. So they're, you know, bigger than California, but they're just way more downloads. And so as you can see here, this is sort of the rate of use in other countries. And it's just, you know, not in, there's some that are in single digits, but there are other countries that are, you know, way much higher download rates. Again, some of these countries require it, like Singapore. But even, you know, in the UK, for instance, we have close to 30% download rate. So early results show that these contact tracing apps can work. So coming from the UK, it's these are sort of estimates done by epidemiologists, because they're using the decentralized database, so they can just sort of track how many exposures per user who exposure notifications per user who tested positive. And they estimated that it might have averted a 250,000 infections between October and December 2020, which is not something to sneeze at. This is when they were hitting their big wave with the variant, the Kent variant. And in the from data from the canton of Zurich in Switzerland found that an increased number of people quarantined when they have adopted these apps, and actually 17% of people notified tested positive. So, you know, these apps seem to work, even the decentralized version that doesn't track location. And so we thought in December 2020, let's do a follow-up study to see in a nationally representative sample of the US, how many people have downloaded these apps. So these are the results. I would take it with a grain of salt because a lot of people said that they've downloaded it, but they live in a state that hasn't even rolled out an app. So I would sort of take that result with a grain of salt, but a lot of people have not downloaded these apps. And so we asked them about, you know, your reason for not downloading these apps. These are all states. And what we found is that a lot of people were not aware that an app was available. That was the first one. I think a lot of states didn't do a good messaging in terms of, hey, this is another thing that you can do to prevent COVID spread besides wearing masks and social distancing and being careful indoors, and outdoors is safer. Contact tracing apps just kind of got lost in the messaging. Again, privacy concern, we see that as an important reason for now downloading these apps. So here are the states with contact tracing apps available at that time. And we found that even though they were available, a lot of people were just not aware that they were available. Another thing to consider is sort of, even if people are aware and they've downloaded it, a lot of people, especially Android users, reported having a sort of negative user experience in the App Store. So we actually scraped all the reviews from the App Stores, and we're doing some interesting machine learning sentiment analysis, topic modeling on these reviews. But here I just want to show some basic results looking at the reviews. And we found that Android users gave lower ratings in the App Store compared with Apple users. And this is a bit worrying if it is such that, you know, Android users are having a worse user experience because they tend to be lower income than Apple users. And it's really concerning that Michigan, of all places, has a really negative rating. And I've read many negative reviews at a time when they're having a big outbreak. So some questions for future research that we're writing up: how did institutional decisions lead to the failure of contact tracing apps? So we're collecting, we're making a data set of universities and whether they have encouraged their students to download contact tracing apps as part of mitigation measures. Actually, just from our initial results, a lot of universities don't have it on their websites. Again, this is part of the bad messaging where a lot of people are not aware this is a thing that they can use. And unfortunately, lower use rates in the population means we get more negative bad reviews in the App Store because people are saying, hey, I downloaded this thing, but it's not doing anything. Is it useless? So there is definitely a collective action problem. We're working on a paper in terms of looking at public trust in institutions and that and how that affects willingness to comply with public health surveillance. And looking ahead, how do we build robust and ethical vaccination verification systems, which is something that my team has been thinking about. And we wrote up a paper for Brookings about it. And you know, we really have to think about it as a system, not just sort of looking at verification methods, a paper card versus an app, but how the data is being stored by your public health providers and how that data is then transmitted to the vaccine passport apps, if that's going to be something that governments launch. And then finally, we have to think about the entities that are requiring proof of vaccination, because I think that's another big thing. And one sort of equity concern that is sort of beyond people not having smartphones is that, as with other COVID prevention measures, we're asking a lot of low-paid service workers to essentially act as the surveillance and policing arm of the state if we're going to be adopting these vaccine passport apps. Then someone has to stand, you know, there to check your phone or maybe a piece of paper. And I already know this is looking at the polling data, this is going to be a polarized issue, as with mask wearing and social distancing and lockdowns. A lot of conservative politicians and also members of the public are just saying, like, this is not something that we want. So I don't know if in the US, I'm sort of hoping that we can get a very fast vaccination rate so that we don't have to worry about proving our vaccines in everyday places, like going to the movies or going to the grocery store or going to a restaurant, because you know, restaurants don't ask about your measles vaccines. But however, I think verification of vaccination is really important for international travel or going on a cruise or, you know, going back to work. So it's definitely a tricky area that my team is continuing to investigate. So thank you for listening to my presentation.
Thank you so much, Dr. Zhang. So we wanted to hear if you have any final words of advice about some of the opportunities, again, like compiling everything that we've learned today. It's It's not something that is easy in terms of like implementing contact tracing, as we've learned today. So if you have any final words to share with the audience, that would be great.
Yeah, I think my advice is that this is an interdisciplinary endeavor. It's not just a public health endeavor, but I think bring in the technologists, bring in the social scientists who study how human behavior will impact use of the technology is quite important. It's really unfortunate that our sort of funding mechanism and how and sort of the economic incentives don't encourage this kind of interdisciplinary work as much. And what worries me is when states are thinking about adopting technology, I was just looking at who they contracted to make these smartphone contact tracing apps. Some states have gone with legitimate organizations, nonprofits, with a lot of technologists and ethicists and others on board who are thinking through these issues very seriously, like the Path Check Foundation or COVID Watch. However, some states contracted with tech firms that have very little experience in the public health realm. And for one of these, I'm not going to mention whom, I can't even find this tech company's website, their URL. It doesn't work. And I think that's kind of scary. You know, we talk about Google and Apple and all these big tech companies doing things. At least, you know, journalists are paying attention and we can sort of know what's going on. Maybe not super deep down, but there are a lot of smaller actors, tech companies, startup types that are sort of flying under the radar. And I think journalists need to be aware that these intermediaries can be as harmful as big tech companies.
Well said, Baobao. And it looks like we only have a couple minutes left, but I'd love to get just a couple final words from our other three panelists. So Eleanor, if you want to jump in quick, if you have any final words.
I was really delighted to hear Baobao's presentation because I think like this is something that we've been tracking for so long, and with, you know, we don't sort of take a stance on what's working on best practices for technology, and that's not our area of expertise, but it's very good to hear somebody who's been digging into those issues more. We're going to be continuing to track contact tracing efforts going forward, and I think one of the things I wanted to flag is that in all of these efforts, and we've been talking about equity to an extent, and I think some of the things we've really been looking at are how to involve community health workers or other types of other portions of the workforce to carry out the COVID response in a more equitable manner and to reach populations that are perhaps not the first to hear about changes to vaccine rollout or what have you. So I think that's something we're going to continue focusing on as well. And of course, we will be working to figure out what has worked best in contact tracing in the United States. So thank you so much.
Yeah, thank you. Torsten, any final words?
Yeah, this has been, you know, I think I'm the outlier in the group in the sense that, you know, what I was doing is looking at legal cases, not at contact tracing apps or statistics. But very selfishly, I've learned a ton during this presentation, and I'm really interested in copying some of my co-panelists' ideas of how they look at data and the considerations they have going into looking at the effectiveness of the contact tracing apps and the use of technology, and try to adopt some of that in the legal realm, because these are all issues that are coming towards the forefront in law firms, and you know, we're generally, lawyers are a little bit behind technologically many other areas of society and academia, but hopefully we'll catch up soon. But I've heard a lot of really interesting stuff and gathered some great ideas.
Excellent, thank you. And then Saad, to wrap it up for us here, any final thoughts?
So I have a sort of, I think there's a lot of detailed discussions and nuances, etc. I have a big picture thought, and I think you know, entities like Thompson Center has a responsibility to make sure that the memory of this pandemic and the lessons learned remains alive and is available for future scholars to dissect in a lot of detail. Because, you know, having been engaged with pandemic influenza plans in the past in sort of in various capacities, et cetera, frankly, a lot of our assumptions were naive. Now when the rubber met the road, there are a lot of things that public health could do, and there are a lot of things public health couldn't do. So I think what worked and what didn't work is just the start of the story. But why certain things worked, why certain things were acceptable, and why certain things were acceptable at a given time and not later, or vice versa. I think, you know, sort of doing serious scholarship around that, but also importantly making sort of that kind of information, that kind of thinking available for future public health leaders would be a critical function that interdisciplinary centers like this one are the ones that are uniquely suited to do. So no pressure, colleagues.
Well said, Saad. Well said. Yeah. So, you know, we're 2 minutes over time here, and I could sit on a call with all of you all day and go through more questions, but I think for the attendees, we'll wrap it up. So first of all, thank you all who were able to join us and learn with us today. To all the panelists, we thank you for not only your time today, but all your research over the past year. What you brought to us was so incredibly enlightening. And I think, at least for me, I'm so much more prepared if something ever like this were to happen again, which I really, really doesn't hope it does, but we're prepared for it now. And I'm going to hand it back to Eric. And I do want to remind you all that at 12:45, UW-Stout CyROC will be putting on an IoT security workshop. And Holly did drop the link to register for that in the chat here. So Eric, back to you, and thanks everyone again.
Excellent. Well, thank you very much. I know we're beyond time today, so I wanted to thank, again, our co-sponsors, each of our panelists. I really want to thank the moderators today for putting the time in ahead of time to coordinate this, and thank you again.